Professor HOD and the moderator for this session, Professor Deepak Naik, our younger brother from Manipal, and Dr. Mohanty from Chennai, as I understand. All the distinguished participants, esteemed faculties of SCB, and my friends from Odisha, India, and even from abroad. It is indeed a privilege on my part to be introducing, giving a little bit of information about the Platinum Jubilee and SCBN Global Conclave. Those who have joined this time and not before, you know that we are celebrating the Platinum Jubilee and SCBN Global Conclave in 3 phases. This is the first page. We have already crossed the 25th mark. We have 37 departments. They are presenting almost every day nowadays. Today is the day for the Department of Otorhinolaryngology. And I am given to understand the expert in their field, they are going to. The second page is starting from 3rd, and that will continue up to 25th of November. And the main function is on 26th, 27th, and 28th of November. And I must give you a warm welcome to this CME, to the 75 for 75 program, and also would definitely request all of you to participate in the Platinum Jubilee and SCBN Global Conclave on 26, 27, and 28. In case the corona situation is not that conducive, we may hybrid or even the digital celebration. But whatever we do, we are going to have a live streaming through the YouTube. The 75 for 75 program is going to be a beautiful program for 75 days, depicting the each year of 75, the glorious year of the history of SCB, and which will be reflected through performance by each department. And in that program, every department has been requested. The program has already been laid out. Every department has been requested to look to the past by felicitating all the faculties of SCB who have contributed in the development of SCB, to deliberate on the present, and they will give a vision for the coming 5 years of their department. And it will be followed by an entertainment program. So everything will be live streamed. As proud alumni of SCB and as part of SCB, I would expect all the SCBians to join physically if it is possible, or at least digitally if they are not able to come physically. With these few words, I again welcome you to this pre-Platinum Jubilee CME on behalf of the institution, and hand over to Professor S.K. Behra to conduct the proceedings.
Thank you, sir. So I'm going to introduce both of our speakers, and to start with, Professor Deepak Ranjan Naik is currently Professor Kasturba Medical College, Manipal. He has 30 years of experience in undergraduate and postgraduate teaching, and he has participated as a faculty in a number of live surgery and live surgery demonstration and CME, and in both national and international level. He has carried out project in recent trend in head and neck and skull-base surgery in University of Illinois, USA. He was a visiting professor to John Hopkins University, USA, and Royal Infirmary Hospital, University of Leicester, UK, and he has more than 125 publications in national and international journals, and he has a special interest in head and neck surgery, oncology, skull-base surgery, endoscopic, transoral, laser, microsurgery, larynx and pharynx. We will be talking on phonosurgery. Now the second speaker, Professor Dr. Sanjeev Mohanty, Is an experienced E.N.T and head and neck surgeon based in Chennai with 25 years of academic and clinical experience. His endeavor for new surgical techniques and modification of existing one is well accepted by, by the members of the E.N.T community. He has more than 60 peer-reviewed papers and in international and national podium presentation, along with 76 original research publications. He has fellowships in Harvard University, uh, New York University, Sloan Kettering Cancer Center, John Hopkins, Tübingen Hospital, Germany, and research center and many more. Uh, there are still more institutes he has gone and interacted. His career interest is in head and neck surgery, implantation, otology, phonosurgery. Recently, he has done a bilateral cochlear implantation. So he will be also speaking on the topic of cochlear implantation. Here, the second speaker. And now I invite Professor Dr. Deepak Ranjan Naik to start his presentation. Professor Deepak Ranjan Naik, kindly start your presentation.
Good afternoon, everybody. Thanks to our Dean of Cuttack SC Medical College, Gupta, and Professor Behra, E.N.T, and all the faculties of the department, besides all our previous alumni, and also the students of and faculty of SC Medical College, Cuttack. So I have taken this topic, principles and application of phonomicrosurgery. So this topic, I'm happy that it was given to me by Dr. Subrat Behra. Phonosurgery has developed since 19th century as an endolaryngeal surgery. Then it was direct laryngoscopic surgery, then microlaryngeal surgery by Klein-Sisters as it developed, and subsequently the concept of voice conservation and voice for surgery for the voice problem, that developed to phonosurgery. So it encompasses a number of surgeries that includes phonomicrosurgery, besides laryngeal framework surgery and injectable and implantable material in the vocal cord procedures. Coming to history, introduction of the term phonosurgery was done by Leiden and Arnold in 1963, which encompasses phonomicrosurgery besides office-based procedures, surgery for laryngoplasty, laryngeal injections, surgical innovations. The term phonomicrosurgery was introduced in 1994 by Gittel. So the basic difference between phonosurgery and phonomicrosurgery, phonomicrosurgery includes everything, and basically surgery done without microscope, and phonosurgery done with a microscope. But just using a microscope is not phonomicrosurgery. So that's why I said microlaryngeal surgery. And to compare phonomicrosurgery, in microlaryngeal surgery you can do with inadequate knowledge of the fine structure of vocal folds, mucosal folds, and you can resect or over resect with postoperative dysphonia and scar formation, because you don't look into the fine structures of the vocal cord. That is microlaryngeal surgery. But when it is phonomicrosurgery, you have to look into the ultra fine microarterial anatomy of the vocal fold before doing any surgery, and you remove the pathology without minimal trauma so that optimum voice outcome can be achieved. Truncation surgery for benign lesions has reached to remove a part of the superficial layer, thereby causing scar formation as you are seeing here. It was described by Hirano. Coming to applied anatomy, the basic and modern phonosurgical technique of voice disorders it is essential to know the structural anatomy of the vocal folds and to have good expertise and also the knowledge of physiological functions of the vocal cord. And one should go to the landmark discussion by Hirano about the microanatomy and functioning of the vocal fold. One thing is mucosal stripping of the vocal fold is not indicated in phonomicrosurgery as is being done in microlaryngeal surgery for malignancy or malignant lesion, suspected malignant lesion that can be associated with scar formation. Coming to ultrastructural anatomy of the vocal fold, most important part is ring space beside the epithelium, and is the ring space. It is between the intermediate layer of the lamina propria and the mucosa. So this layer is vital, and preservation of this layer is essential, particularly to have an optimum voice outcome. When it is damaged, it can cause residual voice problem. Very important to evaluate the case for any phonomicrosurgery that includes auditive perceptual assessment like GRABAS, video stroboscopy. These two are very, very important. Most of the institutions should have. Besides that, if you want a classical voice clinic, like you only deal with voice disorders, you must have electroacoustic analysis for voice signals, aerodynamic measurement, and also salubrity rating by the patient. Preoperative preparation is very important, and patient must receive counseled adequately before surgery, receive maximal benefit of voice therapy. Medical management like laryngopharyngeal reflux disease should be treated beside other vocal fold disease with medical treatment, and patients should be explained about the surgical risk, and no contraindication should be there for the surgical intervention. Counseling and documentations are very, very important, particularly informed consent with respect to that person may lose the voice permanently, risk of associated injury and anesthetic injury. Documentation is very important, and also recording. You should have the recording from medical legal point of view also. Instruments, most important is the laryngoscope. There are different types of laryngoscopes are there. The basically wide whole laryngoscope, particularly wide opening, so that you have adequate space to manipulate your instrument, and you can focus and have a good exposure to the vocal fold. Then high quality operating microscope like JAIS or Leica, so many other microscopes are there. Basically, it should be good with a 400 mm length and good operating chair. If you see this picture, you are sitting at a distance, you're getting a support, and you see the other picture, your hands are stable and close to the patient. So sometimes you find Mayo stand not going up and down, you have to sit as it is because you don't have other choice. So this is very, very important. Comfort of the surgeon to do the surgery, not just surgery itself, but the comfort gives you the most precise resection, and also your hand movement, if at all anything is there, involuntary movement, that can be reduced or minimized. Laser versus cold instrument versus microdebrider. The refinements in handheld cold instruments that facilitate microdissection. Fine microlaryngeal instruments have been developed by a lot of prominent surgeons that are available in the market, particularly by Zomet. And I would prefer the international foreign instrument than the Indian-made instrument, very crude. You want to do microsurgery, proper phonomicrosurgery, you should have the best instruments in hand, particularly cold instrument. If you do not have laser, doesn't matter, but cold instrument should be the best quality. Unlike laser, cold instrument provide tactile sensation during delicate microdissection, particularly in the microflap technique. Laser is used when the pathological condition is vascular or it's too large, or it is a malignant or pre-malignant lesion. Power instruments are good for laryngeal papillomastosis and also for debulking. Here are the micro instrument that should be available for phonomicrosurgery. Sometime in a teaching institute, whatever is available with that, you have to, with minimal trauma, you have to do. What I'll show is my experience with the minimal instrument that is available in a medical teaching hospital. So most of these instruments are not available. Sometimes we are given laser, but you are not given the micro instrument that has to be used for laser. So there is a status sometimes in a hospital, particularly in teaching hospital. Phonomicrosurgical principle, providing a smooth vocal fold aids for oscillation. conserving the epithelium and underlying superficial lamina propria, attention to the layered structure so that the mucosal wave pattern of the vocal fold is not affected, minimal excision of tissue, minimal rupture of superficial lamina propria. Primary goal to improve voice quality while dealing with the pathology, respect the structural layer of the vocal cord, minimal excision of tissue, as I said. So refinements in handheld cold instrument facility, I think I've gone down. Yeah. Surgical technique, cold instruments, the microflap technique, which is a medial microflap technique or lateral microflap technique. Subepithelial infusion of 1 in 10,000 epinephrine saline to the lamina propria is very, very important for hydrodissection, sometimes for superficial lesion, even if carcinoma in situ or a pre-malignant lesion will be lifted off from the vocal ligament and make it easy for you to dissect and take out and while preserving the lamina propria. Incision, elevation of microflap, subepithelial removal, and flap repositioning. These are the important steps of the microflap technique. Phonomicrosurgery application. You can do with cold instrument, laser, or with injectable material. Sometimes may require cold instrument, microflap technique for benign lesions, cyst, vocal nodule, polyp, etc. Truncation surgery, pedunculated lesions, like here, pedunculated lesion at this side with minimal tissue loss, so that you don't have much voice problem post surgery. Laser assisted phonomicrosurgery like pre-malignant lesion, early malignant lesion, neoplastic lesion, granulomas, dystonia, spasmodic dysphonia, etc. Injectable implantable procedure, injection laryngoplasty to paralyze vocal cord with fat, injection of hydrogen steroid for fat for vocal cord scarring, interlesional steroid, and pseudofovir injection interlegionally for laryngeal papillomatosis. Vocal cord cyst. We expose, good exposure important, infiltrate saline so that the ringing space is open and the mucosa get lifted off. Then make the incision so that your knife or the elevator edge should be visible while elevating the mucosa, and then you dissect, and you can use small cotton ball or surgical petty and then dissect gradually and take out the mass without injuring the epithelium, which can be opposed. This is a difficult case. I am finding difficulty in exposing the anterocommissure area very close to the anterocommissure. My assistant is putting counter pressure, then rotating the larynx so that this lesion can be exposed. And you do micro dissection. Sometimes the lesion may be adherent to the epithelium, like in this case. In that case, don't dissect the entire segment. You elevate at least most of the part of the vocal fold, the mucosa, and resect it so that adequate mucosa at the free edge of the vocal cord is preserved so that it can produce minimal scarring and give a good voice outcome. This is a small video I'll show you. Infiltration is the lamina propria, particularly in case space. Incision with the seizure itself, I use a seizure for dissection and incision. We don't have any instrument for the knife and other thing, but that doesn't hamper in doing the surgery. And your tip of the instrument should be visible through the mucosa. That means you're intact, and should not perforate the mucosa because that will produce scarring. As you see here, the mucosa is elevated, the instrument can be seen. So as you dissect, then you do blunt dissection. Use surgical petty to dissect the lesion from the bed. Neurosurgical petty can be made into small pieces. Your forceps, micro forceps, cup forceps can be, while closing, can also help you to dissect, give a blunt dissection, and then you can remove the mass successfully. With complete preservation of the mucosa. So it can be applied for vocal nodule. The principle is same, elevation and nodule polyp with a mini microflap, small microflap lateral to the mass is done. The mucosa is elevated laterally and again inferiorly. The subepithelial content is removed after remove the mass and the, as you see here, and the epithelium is opposed. Same thing, vocal cord polyp, subepithelial dissection. This entire content of the mass should be taken out and reapposed. Laser assisted phonomicrosurgery. Laser, particularly carbon dioxide laser, known for its precision. You can give the incision, lift up the mucosa from the bed, preserve as much as mucosa possible so that you can oppose it and resect the mass without disturbing the vocal ligament and lamina propria. Best for the vocal cord granuloma can be excised at its attachment without minimal scarring. The carbon dioxide laser doesn't produce any scar formation after resection. Minimize. Here you see that the lamina propria is preserved, only epithelial surface taken out along with the mass. That is very crucial. Unless it is malignant, you have to